Hey, good afternoon, everyone. It's just about a minute until noon. I'm going to go ahead and give this just a few more minutes because people are still trickling in. Hey, everyone. Thanks for joining our monthly Lunch and Learn. I'm going to go ahead and get started. So a few more people trickling in. Um, Grab a drink and we'll go ahead and start talking. This is going to be about heart failure with a focus on documentation that supports accurate and complete risk adjustment. And just a little about me. My name is Jolene Hansick, and I'm a nurse practitioner and a certified risk adjustment coder. My clinical background is primarily in emergency medicine and some primary, and I've been doing risk adjustment with Vatiga for a little over 4 years, and I do still practice clinically part-time. And this presentation was developed in collaboration with Dr. Jacob Utash. He's our Senior Vice President of Clinical and Quality. He's also a family medicine physician and certified risk adjustment coder. He has extensive leadership roles in quality, clinical documentation, and risk adjustment. So here's the game plan. We're going to start with a quick review of the clinical classifications of heart failure. It's topics you're already very familiar with. But next, we'll discuss documentation and coding for heart failure, including combination codes, and work through a couple of case studies. And then we'll wrap up with some practical documentation tips and a live question and answer session. So, as always, just feel free to drop your questions into the chat at any time. So just to get started, let's talk about why coding matters to us as providers. These ICD-10 codes, they translate our clinical diagnoses into standardized data. And then that data, it goes out, it's used for many purposes. It can be used for medical research, quality reporting, public health, disease surveillance, determining medical necessity and reimbursement. Documentation and coding, it also drives risk adjustment scores. And these scores reflect the complexity of the patient's health status, and they help to determine the resources needed to care for that patient. Those resources support things like care management, medications, social support services, and preventative and chronic disease programs. Healthcare is under extreme financial pressure and regulatory scrutiny, so it makes accurate documentation more important than ever. So for providers, accurate documentation, it ensures a medical record reflects the full complexity of the patient's health status. It supports evidence-based treatment decision. It demonstrates medical necessity, and it helps support appropriate reimbursement. And most importantly, it benefits our patients. Accurate documentation, it helps identify high-risk individuals, it directs resources where they're needed the most, and it helps patients receive the benefits and services that reflect their healthcare needs. And the reality is that risk adjustment depends entirely on what we document, and unfortunately, most of us were never formally taught coding, and clinical practice doesn't always align with coding requirements, and that's what these lunch and learn sessions are for, to help bridge that gap between clinical practice and coding so your documentation reflects the excellent care you're already providing. So before we get into documentation, let's do a quick review of the basics of heart failure. It's just enough to set the stage and highlight where clinical practice and coding differ. Most of this review comes from the 2022 AHA-ACC heart failure guidelines. So heart failure develops when structural or functional changes in the heart impairs ventricular filling or the heart's ability to pump blood effectively, leading to these characteristic signs and symptoms. The key point is that patients must have current or previous signs or symptoms of heart failure and objective evidence of cardiac dysfunction. So what are some of the signs of heart failure? Patients might present with dyspnea, orthopnea, paroxysmal nocturnal dyspnea, PND, decreased exercise tolerance, fatigue, or swelling. On physical exam, you might find elevated JVD, a third heart sound, peripheral edema, pulmonary rales, a murmur, or weight gain. And objective evidence, it may include a reduced ejection fraction, structural heart disease like left ventricular hypertrophy or chamber enlargement, or other imaging abnormalities that consist with heart failure. Hemodynamic measurements and cardiac biomarkers like a BNP also provide evidence of elevated filling pressure and support the diagnosis. So let's look at the ACC-AHA stages of heart failure. These stages, they describe a continuum of heart failure from patients who are at risk to those with advanced disease. And they're based on the presence or absence of risk factors, structural heart disease, symptoms, and cardiac biomarkers. So stage A, this is the patients that are at risk for heart failure, but they don't have symptoms, structural heart disease, or evidence of cardiac stress or injury. These are patients with conditions like hypertension, cardiovascular disease, diabetes, or obesity. Not all of these patients are going to develop heart failure, but the focus this stage is prevention and modifying risk factors. Stage B is also called pre-heart failure. It includes patients who don't have current or prior signs and symptoms of heart failure, but they do have structural heart disease, evidence of increased filling pressure, or elevated cardiac biomarkers. And stage C is symptomatic heart failure. So these patients have current or prior signs and symptoms of heart failure, along with objective evidence of structural or functional heart disease. And once a patient has both the symptoms and objective evidence, they meet the definition of heart failure. At this stage, our goal is to treat the heart failure and prevent progression to stage D or advanced heart failure. So next, let's talk about the classifications of heart failure. And this is an area where coding hasn't quite caught up with the clinical world. just very broadly. Heart failure can involve the left ventricle, the right ventricle, or both. And from a coding perspective, left heart failure is still classified as systolic, diastolic, or combined, even though clinically we now focus much more on ejection fraction than systolic versus diastolic dysfunction. The terminology, it is outdated, but we still discuss it because ICD-10 coding continues to rely on it. So we'll start with left-sided heart failure, which is the most common type of heart failure. And when we talk about left-sided heart failure, there's two traditional subtypes, systolic heart failure and diastolic heart failure. In systolic heart failure, the left ventricle doesn't contract effectively. Several conditions can damage the myocardium and impair this contractility. Some common ones are chronic hypertension, myocardial infarction, dilated cardiomyopathy, and valvular heart disease. So when the left ventricle, it can't contract well, it struggles to pump blood forward into the body. So this is a forward flow problem that results from reduced cardiac output. On the echocardiogram, this reduced pump function is reflected by a decreased left ventricular ejection fraction, or LVEF, which is the percent of blood pumped out into the ventricle with each heartbeat. When the LVEF is 40% or less, this is classified as heart failure with reduced ejection fraction, or HFrEF. Clinically, HFrEF is another way of describing left systolic heart failure. Another type of systolic heart failure is heart failure with mildly reduced ejection fraction, and these patients have an LVEF between 41 to 49%. So now let's look at diastolic heart failure. Unlike systolic heart failure, which is a problem with contraction, diastolic heart failure is a problem with relaxing and filling of the left ventricle. It develops when the left ventricle becomes stiff. It can't relax during normal diastole. The most common cause is chronic hypertension, which increases afterload and it forces the heart to work harder. Over time, the left ventricle muscle, it becomes thicker, a process called left ventricular hypertrophy. Other causes are aortic stenosis, ischemic heart disease, diabetes, and certain cardiomyopathies. So as the ventricle becomes thicker, it becomes less compliant, it can't fill properly. And because blood enters the ventricle during diastole, stroke volume and cardiac output decreases. And even though the heart's ability to contract is preserved. So since contractility is maintained, the left ventricular ejection fraction remains preserved. And this is called heart failure with preserved ejection fraction, or HFpEF, and it's defined by an LVEF of 50% or greater. So let's shift to right-sided heart failure. The basic pathophysiology is similar, but clinically, we don't usually distinguish right-sided systolic from right-sided diastolic heart failure the way we do on the left side. The most common cause of right-sided heart failure is left-sided heart failure. Other causes are right ventricular myocardial infarction, pulmonary hypertension, and other chronic lung disease. It's a little different from a coding standpoint. ICD-10 does not separate right heart failure, systolic and diastolic categories the way it does for left-sided heart failure. So for coding, we simply have right heart failure, and then we document the cause or related conditions when known. So just to summarize that, the newer classifications of heart failure is based on left ventricular ejection fraction, or LVEF. Using this LVEF, it better identifies patients who benefit from guideline-directed medical therapy, and it aligns with current heart failure guidelines. With systolic heart failure, the left ventricle has reduced contractility, resulting in a reduced ejection fraction. And this is called heart failure with reduced ejection fraction, or HFrEF, and is defined as an LVEF of 40% or less. With diastolic heart failure, the left ventricle becomes stiff, it doesn't fill properly, and because contractility is preserved, the ejection fraction remains preserved. And this is called heart failure with preserved ejection fraction, or HFpEF, and is defined as an LVEF of 50% or greater. Now, between these two groups is heart failure with a mildly reduced ejection fraction. And these patients have an LVEF between 41% and 49%, and they often share characteristics of both HFrEF and HFpEF. And then finally, there's heart failure with an improved ejection fraction. And this is used for patients who previously had heart failure with a reduced ejection of 40% or less. And with treatment and follow-up, they have an LVF of greater than 40%. So according to AHA/ACC guidelines, this is a subgroup of heart failure with reduced ejection fraction. They elect not to use the term recovered because even though the ejection fraction is improved, guideline-directed medical therapy should be continued because the patients remain at risk for a recurrent heart failure. So that brings us to coding, and where clinical terminology and ICD-10 coding don't always match. So current heart failure guidelines, they classify it with ejection fraction, but ICD-10 is still using systolic and diastolic. So to bridge that gap, the AHA coding clinics published some guidelines that explain how today's terminology translates into ICD-10 codes. So one of the first things you'll notice is ICD-10 codes for left-sided heart failure, they're not specifically labeled as left, while the right-sided heart failure is. So if the code doesn't specify right heart failure, it's probably referring to left heart failure, and the exception is biventricular. For each type of heart failure, so left-sided HFrEF, diastolic HFpEF, combined, and right ventricular failure, there's a separate code for unspecified, chronic, acute, and acute on chronic heart failure. So for example, we have heart failure with reduced ejection fraction, or left systolic heart failure. Assign the most specific code from unspecified systolic heart failure, chronic systolic heart failure, acute systolic heart failure, or acute on chronic systolic heart failure based on documentation. So for heart failure with a preserved ejection fraction, or left diastolic heart failure, assign the most specific code for unspecified diastolic heart failure, chronic diastolic heart failure, acute diastolic heart failure, or acute on chronic diastolic heart failure. So the AHA/AC guidelines, they describe mildly reduced as having characteristics of both HFpEF and HFrEF, and that it may be improving or deteriorating. Now, there's a coding clinic that guides us to assign chronic systolic heart failure for heart failure with mildly reduced ejection fractions. The AHA/ACC guidelines, they also state heart failure with improved ejection fraction is a subgroup of heart failure with reduced ejection fraction. And that makes sense because the EF had to be less than 40% at some point to have improved to greater than 40%. So heart failure with improved EF, you use a code for chronic systolic heart failure. So now let's look at combination codes. We're not going to spend a lot of time on hypertension and chronic kidney disease because that's a topic all in itself. It has its own dedicated lunch and learn. So you can watch that on demand on our website. ICD-10 guidelines, they presume a causal relationship between hypertension and certain heart conditions, including heart failure, and between hypertension and chronic kidney disease. So when a patient has hypertension along with certain heart conditions, either with heart failure or without heart failure and or CKD, these are identified using specific combination codes to capture both the hypertension and the related condition. So in other words, coding guidelines always assumes these conditions are related unless the provider clearly documents they're unrelated. So let's start with hypertensive heart disease without heart failure. And this one is kind of confusing because the term heart disease is so broad. ICD-10 guidelines, they identify specific heart conditions that are presumed to be related to hypertension. So these are myocarditis, myocardial degeneration, cardiomegaly, left ventricular hypertrophy, and heart disease unspecified. So unless you clearly document that these conditions are unrelated to the patient's hypertension, then they are coded as hypertensive heart disease. A really common example is a patient with hypertension, and they have an echocardiogram that shows left ventricular hypertrophy. If there's no documentation stating that the LVH is due to another cause, then the coding guidelines presume it's related to the hypertension, and we use I-11-9 for hypertensive heart disease without heart failure. Now, if in your clinical judgment, another heart condition is related to the patient's hypertension, but it's not one of the conditions specifically linked by the ICD-10 classification, then you document that relationship using terms like with, associated with, or due to. And that documentation allows a coder to assign the appropriate hypertensive heart disease combination code. So here's all of the hypertension combination codes. I know this looks like a really busy table. It reminds me of an algebra equation, but it's pretty straightforward once you break it down. So start with the first question. Does a patient have plain old hypertension? And if the answer is yes, there's no related heart or kidney conditions, the code is simply I-10 for hypertension. Next, ask yourself 3 questions. Does the patient have one of the heart conditions presumed related to hypertension? So we're looking for things like LVH, myocarditis, or cardiomegaly. Next, does the patient have heart failure? If so, what type of heart failure? And third, does the patient have chronic kidney disease? And if they do have CKD, what stage is it? So the table is just different combinations of these 3 conditions: heart disease, heart failure, and CKD. I think it looks a lot more complicated because there's a separate code for CKD stage 1 through 4 and CKD stage 5 or end-stage renal disease. But once the appropriate combination codes assigned, then you use additional codes to identify the type of heart failure and the stage of CKD when those conditions are present. So let's put it into practice with a couple of case studies. Case 1 is a 76-year-old patient who comes in for a 3-month follow-up. He has a history of longstanding hypertension, type 2 diabetes, CKD stage 3A, and heart failure. He reports chronic dyspnea on exertion and 2-pillow orthopnea, which are both unchanged from baseline. His echocardiogram from last month showed an LVEF of 35%, so clinically he has heart failure with reduced ejection fraction, or HFrEF, and he meets the ACC-AHA stage C heart failure criteria. His kidney function's also been stable with 2 GFR values in the CKD3A range over the past 6 months. You review his medications and see that he's on guideline-directed medical therapy that's managed by his cardiologist. On exam, he has mild bibasilar rales and 1+ lower extremity edema, both unchanged from baseline. So you continue his current medicines, order routine lab studies, reinforce sodium restrictions, and arrange close follow-up with his cardiologist. So in this case, we know the patient has HFrEF, CKD stage 3A, hypertension, and diabetes with CKD. So we can assign the accurate codes. I-13 for hypertensive heart and chronic kidney disease with heart failure. I-5022 for chronic systolic heart failure for the HFrEF. E-1122 for type 2 diabetes with CKD. And N-1831 for CKD stage 3A. So the second case is a 69-year-old woman. She comes in for her 6-month follow-up. She has a history of long-standing hypertension and heart failure with a preserved ejection fraction, or HFpEF. An echocardiogram from 3 months ago, it showed an LVEF of 55% with diastolic dysfunction. Today, her weight's stable, she's feeling well, and she reports no worsening symptoms. On exam, there's no evidence of volume overload, so you decide to continue her current treatment plan. So to capture her conditions as specifically as possible, we sign I-11 for hypertensive heart disease with heart failure, along with I-5032 for chronic diastolic heart failure for the HFpEF. So to summarize, here's some key documentation points. Document the clinical history and physical exam findings that support heart failure. So include symptoms like the dyspnea, orthopnea, P&D, edema, and weight gain. And remember that the diagnosis of heart failure, it requires current or previous symptoms along with objective evidence. Document the diagnostic evidence that supports heart failure, like the echocardiogram findings, EKG results, BNP, or hemodynamic measurements when appropriate. Document the status of the heart failure. You can describe it using the ACC-AHA stages on a continuum from those at risk to those with advanced heart failure, and document the acuity. Is it chronic, acute, or acute on chronic? Finally, document the treatment plan. Include guideline-directed medical therapy, medication changes, any diagnostic testing, referrals, and follow-up. Select the appropriate combination code. Document the most specific type of heart failure. And if there is CKD, document the specific stage. Okay, so that wraps up heart failure documentation and coding. Lots of information we covered, but as always, you're going to receive a copy of the slides by email. So Vatica has grown significantly. So we're going to do a trial of offering 2 lunch and learn sessions to cover everybody. So the first is this one held at noon Eastern, and we're going to have a second session at 3 p.m. Eastern. And we hope this later option will make it easier for those in the Pacific time zone to attend during their lunch hour. And as always, you can always watch a replay of this session along with all of our other Lunch and Learn presentations anytime on demand at vaticahealth.com. And if you're looking for more in-depth education, we also offer 3 live 1-hour seminars each year that are approved for Category 1 CME credit, and they are updated annually. We've already presented 2 CEU seminars this year. If you missed them, they're available on demand on our website. And our 3rd CEU is going to be in October, so we hope you can join us. And next, we'll open it up for the live questions and answers. You can type them into the chat. And if something comes up later, you can always reach us at providereducationsupport@vaticahealth.com. This email goes directly to Dr. Utash and myself. We're always happy to help. If you prefer, we're always happy to schedule a one-on-one session. We can discuss specific questions or even patient cases because we truly appreciate the opportunity to support our providers. And thank you so much for joining us today, and we hope to see you in the future. And it looks like we do have a few questions. Okay, so the first question is, why did we assume the acuity of chronic if it wasn't documented? There actually is a coding clinic. Here it is. That heart failure with a mid-ranged or mildly reduced ejection fraction is to be assigned the code chronic systolic heart failure. And I would say that it's also very much a provider's clinical decision making. Just thinking through clinically, if you have an improved ejection fraction, you're probably not acute. Let me go back to this slide. This is a good one to use. So systolic, we know, is going to be the HFrEF. and subsets of that are mildly reduced and improved. If you're improved, you're probably not going to be acute, but the documentation guides us towards chronic in that scenario. And it's, the provider's clinical judgment as far as what to use. But typically it's going to be chronic, especially for risk adjustment. We're most likely going to be capturing the chronic. The I-59 code will not be an HCC diagnosis. I have not heard that. I will have to look that up. I'm going into coding clinic and I'm going to look up I-59 real quick. So at this point, it is a I-50.9, which is heart failure unspecified, is a CMS 28 HCC. I hope they don't take that away as an HCC. Even if the heart failure is unspecified, we all know there's a lot of resources needed to care for those patients. But thanks for sharing. I'll definitely look that up. So how about patients with hypertension, LVH, without heart failure? So essentially preserved ejection fraction. So you said it in this statement, without heart failure. So that would be hypertensive heart disease without heart failure. You can presume a causal relationship between the left ventricular hypertrophy and the hypertension. So you can assign that combo code, hypertensive heart disease. But if they don't have heart failure, then it's without heart failure. And will we receive slides? Yes, we do always. It's usually by the end of the day, you're going to get an email and it will have the slides for today's presentation in it. And I'll hang out here for a couple of minutes and see if there's any other questions. And have a thank you, and it's my pleasure. I hope you all enjoyed it. And how current does the echo need to be? So that again, that's a provider's clinical decision making as far as what they're going to use. I can tell you that just from Vatica chart review, that we will take diagnostic studies up to 5 years old to present to the providers and determine if that's, and let them determine if it's an active medical condition. I certainly hope if we have a patient with heart failure, we're probably getting these echoes at least every 1 or 2 years. But to answer your question, how long ago the echo needs to be, it's a clinical decision making issue. It's not a risk adjustment defined criteria. So, at least 5 years, yes. Any other questions? Okay, I have 12:35, so I'm going to go ahead and sign up. But if you guys think of anything, please send us an email. Have a great rest of your day, and we hope we'll see you next month. Thank you. Bye bye.